again, I'm trying to do this chronologically. I really want to give you context in what I'm doing. So the patient has been assessed. You've thought about optimization steps. You've consented the patient. You outlined some surgical issues, and then it's time to make a basic anesthetic plan. One of the things that was puzzling to me, and actually just put your hands up if you've done anesthetics, did it feel like, obviously a leading question, but did it feel strange when you were asked an anesthetic plan that you didn't have a structure or didn't know exactly what to mention to your consultant? Was that a thing for most people or anyone? Yeah, good. And that's definitely what this is going to target. Again, I'm going to make it necessarily basic because these are the common points, but then I'll go through something later about how to focus on the critical issues as well. So we'll try to have our cake and eat in this situation. So your basic anesthetic plan that you'll time and time again in your first 3 months have to make decisions on is simply these things: GA or regional or just local sedation. Which components of the anesthesia triad do you need? And often that question is really, do I want paralysis or not? Do I want an ETT or an LMA? And do I need any additional monitors aside from all the usual things that the nurse will probably have ready? So do I need an art line or a CVC is often that question as well. Finally, what pain medications do you want? And do you want to supercharge your pain management with a PCA, regional block, acute pain service, ketamine infusion, whatever? And then where's this patient going? Post-op care, is it HT or ICU? So not every case will it be relevant in. Like if you've got that nail bed repair, great, local sedation, nothing else really needs to be addressed. And they're definitely, you'd feel a bit silly offering that information that, oh yeah, I would now not send the patient to HTU. It'd feel a bit silly. So just use your judgment with that. But this hits the high points of what your boss needs to know and what your assistant or your nurse needs to know in getting things ready as well. So approach to every general anesthetic. So when I first learned this, you learn about hypnosis, analgesia, and paralysis. One of the first questions you're asked during your rotation, what's the anesthesia triad? That's it. And when I thought about this, I thought, I get this, right? This is really what the patient and the surgeon want. The surgeon really just cares that the patient's still enough to do the surgery effectively. And the patient, if I was a patient, I just don't want to remember anything and I want to have really good pain relief. So the triad really is addressing that. And so we just have a whole bunch of really amazing medications that can give you hypnosis, give you analgesia and paralysis. But the strange thing is that these medications also have really, really bad side effects and drop your blood pressure, stop your breathing, and have all these other problems that could occur like nausea, vomiting as well. So then you do the anesthesia triad, plus you manage everything in regards to, antiemetics and antibiotics and DVT prophylaxis, and you give lots of stuff for that. And then you manage all the cardiorespiratory complications. So just to give this significance, the whole reason that I've got a job is that my medications are too crap in the sense that they will always have these really bad complications, even though they're really good at very specific things. And because of that, I have a job and I need to intubate and constantly resuscitate patients. Every anesthetic is a balance of the above requirements. First question is, do I need paralysis? I'll just go through this. So paralysis really is surgical. Does the surgeon need the patient to be critically still, such as neuroanesthesia or very fine microsurgery? Or does the surgeon need surgical access? So they need a really good vision of whatever's going on, such as laparotomies and laparoscopies or thoracotomies. You just don't want muscles contracting on the surgeon's space. And these are really the only reasons surgically that you need paralysis. The anesthetic reasons are if you're doing a rapid sequence induction or intubation, it's far better and easier to put a tube down if the patient's paralyzed. And finally, the patient. If there's significant lung disease in a patient, almost invariably they're easier to ventilate if they're paralyzed. And so I might give paralysis simply because the patient's got seriously bad asthma or COPD, or they're very obese and it's caused some effective restrictive lung disease. So that's whether I need paralysis or not. The airway I use really is, my choices are ETT or LMA. And so an endotracheal tube is often in a paralyzed patient, but the reasons are slightly different. They only overlap in a very small area, which is if I need airway protection, I'll paralyze to put a tube down. But the other reasons are shared airway. So imagine, that operation where the surgeon's in amongst the airway, the vocal cords, or I need really precise control of ventilation. Again, a long case, lung disease, neuro cases, or very unwell patients. And that's it. Back in the day, before we had laryngeal mask airways, one of my bosses was telling me, you just hold the mask, the bag mask, for the entire case. So the reason you put a tube in was because the case was taking a bit longer and you just needed your hands free. So these days we've replaced the bag mask indications with LMA. So LMA is really for any patient who's uncomplicated, fasted and well with no airway issues. And that's about 75% of all anesthesia. You'll get very, very used to making the decisions on paralysis and ETT. So I won't dwell on that too much. And it's far better to do it in a case-based fashion. The monitors I need. So standard anesthetic requires a lot of mandatory and readily available monitors. And so you'll be familiar with pulse ox, BP, end tidal, and ECG. But also monitors in the anesthetic machine are just done. You don't even have to ask about them, but there's lots of pressure alarms and you'll hear them going off all the time. Volume alarms, volatile agents. But the extra ones I want you to think about are, do I need an art line? CVC, you can request, BIS, temp probes, neuromuscular monitors, and urine output as the kind of, low-end monitors, and then fancy cardiac output monitors as well. And in some cases, you might even want transesophageal or transthoracic echo. The pain plan, a lot of you would already have seen. Often patients will have pre-medication with paracetamol and ibuprofen before theater. You might, generally speaking, give alfentanil, fentanyl for induction, then fentanyl or morphine for the operation. So just get used to asking and making decisions about that. And then if you think the patient's at high risk of post-op pain, regional anesthesia, ketamine, pregabalin, lignocaine infusion, and magnesium. If you have a patient who's in that kind of situation, just ask your boss, can we try running this or that? And better yet, look up the recent paper on how to run lignocaine and then offer that as a suggestion for your next big laparotomy. In PACU, there's often fentanyl or morphine protocols, roughly 20 mics every 5 minutes to a total of 100, or 2 milligrams of morphine every 5 minutes to a total of 10. And then on the ward, do you want the acute pain service, a PCA for the patient, regional infusions, or ketamine? And finally, does the patient need a HDU ICU? And this is often for these indications. So ongoing airway, breathing, circulation support. Do they have a decreased GCS for any reason? Renal failure, complex pain issues. Imagine that patient on Suboxone high dose, having a very high risk operation. It will be just so hard to titrate the medications. That's why you might need ICU. Complex coexisting disease or complex nursing requirements. All good reasons to refer to HDU. Let's make this basic anesthetic plan. So again, I'm going to get you guys to talk through this for the next few cases.
GA versus regional.
And often these ones are sedation, but you could argue that you get so much sedation that it looks like it's a general, but keep going, that's good.
Then hypnosis and analgesia. Mm-hmm. I wouldn't expect you need paralysis.
Correct, you have the spont venting with the sedation.
For like airway, if they're just sedated, they don't need intubation. Mm-hmm. So you'd have a Hudson mask.
And because it's a gastroscopy, like yeah, exactly. You have a bite block or a nasal prong, absolutely right.
Monitoring, you'd have basically like saturations, ECG, blood pressure, all right. You'd have minimal pain as well, and then usually you can go home as a day case that day. So post-op care would just be recovering. And
this will be the bread and butter of what you do for every sedation case as a gastroscopy colonoscopy. You're absolutely right. And what would you ask for the analgesia component?
You would ask for some fentanyl for short acting.
Absolutely. So I really just ask for fentanyl, and maybe some people ask for midazolam. There's so many ways consultants will do this. Some just do it on propofol alone, others propofol fentanyl, others propofol midaz fentanyl. But I just, again, with this next series of exercises, I just want to give you a bit of an insight into what each of these cases would roughly have when you're going through anesthetic rotation. Okay, so yep, sedation, hypnosis, nasal prongs, BP and SATs usually, ECGs available, pain's minimal, so just fentanyl intra-op, post-op care as a day case. Okay, this one, 35-year-old male for inguinal hernia repair, active reflux.
So my thought for this patient would be that in terms of the triad of anesthesia, they need hypnosis and analgesia, plus minus paralysis, depending upon the approach that the surgeons are planning on taking.
Yep.
But probably paralysis.
A quick question,
is it? In the context of the
quick question, could you do a GA
reflux,
or regional?
I would look to optimize that in the anesthetic bay or preoperatively if I could, using the fancy drug that we've just learned about called sodium citrate here. I would probably give them an ETT in the context of they're probably having paralysis anyway, and also to prevent aspiration. In terms of pain management, I might consider something like intraoperative fentanyl as well as the routine pre-medications, and then some PRN fentanyl for the recovery bay, and then also consider doing a having a look at their risk of postoperative nausea and vomiting. I wouldn't refer to the acute pain service unless there was something in the background, such as addiction, or they were a Suboxone patient, or they had chronic pain problems, and I think they could probably go to the ward after the procedure.
That's great. And so just to give a bit of insight, most people do GA, but regional is absolutely possible. You can do these under spinal as well. But yeah, I'd agree. The triad, I would give paralysis now for the tube because there's reflux. And that's really the only reason. You don't need paralysis for these cases. Most of them are done with an LMA and no paralysis because it's reasonably peripheral, and the surgeons don't need that much exposure. Airway, ETT, because of the reflux monitoring standard. Pain, I completely agree. You can give pretty much anything multimodal plus fentanyl and or morphine. And then post-op care is often just the ward, if not a day case. So that's great. Let's keep going. 50-year-old female, laparoscopic cholecystectomy with well-controlled asthma.
Given that the background is asthma, and presumably given it's going to be laparoscopic, I'd go with the general anaesthetic. I probably would consider the patient to be intubated with an ETT, only because I remember a long time ago, if they had a laparoscopic procedure, they had to be ETT'd.
Yep.
I'd give pre-op analgesia as well. Monitoring would just be the usual blood pressure, pulse ox, and tidal, and ECG. I don't think she probably needed anything more. And pain plan would just, I think post-recovery could probably go to the ward.
Absolutely, that sounds great. So general anesthetic, you'd need all of the triad for this. Airway is a tube, monitoring standard, pain, just fentanyl plus or minus morphine, depending on how much fentanyl you give, post-op care in the ward. Very rarely, if you work with a fast surgeon, there's a bit of a rule. So, I've never done this case on an LMA, but in certain places with certain surgeons, some people rarely would do an LMA for these cases, but that's just not something you'd probably do in your training. There's this rule that if it's less than 15 minutes, less than 15 degrees head down, and less than 15 centimeters water of pressure intra-abdominally, then maybe you can do it with an LMA. But it's just not something I would say that you'd want to recommend unless your boss is doing that. That's good. So we'll get a bit more complicated now. So 65-year-old male, revision total knee replacement, hypertension, cholesterol, a STEMI 1 year ago, and aortic stenosis. Again, just focusing on the intraoperative plan, your basic anesthetic plan. So just to give you a guys' perspective, a lot of these total knee replacements and total hips are done under spinal anesthetic, but they could absolutely be done on general as well. There's a thought that if you give a spinal anesthetic, you have less ability to support the blood pressure, which is very important in aortic stenosis. So there's kind of a cultural thing in Australia that you do a general anesthetic if you have severe aortic stenosis or some level of aortic stenosis. Some finer detail, if it was severe symptomatic aortic stenosis, you'd probably want an operation before this, but that's another topic. So the triad, hypnosis, analgesia, I'd give paralysis just to limit the doses of propofol I'd need. So I'd give paralysis to make it more hemodynamically stable. The airway would be, again, an LMA or an ETT. It doesn't really matter in this case. And as you can see, the indications for paralysis are very separate to the indications for an airway. Monitoring, I definitely have an outline in addition because I want to really maintain that map to make sure that I have good coronary perfusion pressure. So think of this as an aortic stenosis recipe is GA, gentle induction with outline. And we'll go through that in the induction section in more detail. And often the pain can be a lot of things, but yeah, often we want a spinal in, not in this case, multimodal analgesia. Often they'll have a nerve block if we're worried, as well as PCA and pain service afterwards. And if depending on how bad the aortic stenosis is, then you may have to send this patient to a HDU setting, but most knee replacement patients will go to the ward.
Haley here, a quick question.
Yeah,
paralysis if unwell, can you explain that a little bit further, why paralysis is beneficial?
Absolutely. So as you notice, I mentioned that the triad of that in the triad, the surgeon needs paralysis. When you have an LMA anesthetic, you don't need to paralyze because you don't need any significant paralysis to put a tube down. So think about the fact that you're giving propofol and fentanyl and then putting an LMA down and somehow keeping the patient still enough for the surgery. The reason they're still enough for the surgery is that you've given enough of the opioids and enough volatile or propofol to keep them really flat for the operation. If I give paralysis, that means I don't have to use higher doses of propofol and volatile to get the patient also still. So I could minimize my propofol or volatile doses because the patient's already still enough just with the definitive paralytic agents that I've given. Just let that sink in a bit, because a lot of the time your association of an LMA case is like, oh yeah, LMA is more gentle. It's a gentle, and it doesn't need as much stuff going on. But in reality, you have to give more propofol to put an LMA down than you would have to necessarily for a tube. Does that make sense? So in this particular case, I would give far less propofol because I didn't need to, get the patient flat enough with propofol to put the LMA down. And then also during the case, I could run it with far less anesthetic, or a bit less anesthetic. I could also use a biz then to make sure that I titrate it to the right level. Okay, getting a bit more complex now. 70-year-old laparotomy for bowel cancer, severe restrictive respiratory disease, chronic back pain on a whole bunch of OxyContin daily. General anesthetic for this case, hypnosis, analgesia, and paralysis for surgical reasons, but also, and I need paralysis because of the severe restrictive lung disease as well. Airway ETT, monitoring, essentially because it's a bowel operation and they're over 70, most people would probably put an art line in, and maybe you'd have to take gases depending on how bad the lung disease is. And then this is where I can really kind of shine with my pain plan. If you're presenting your pain plan to your consultants, you'd want a multimodal approach, and you can give big doses of fentanyl plus run ketamine plus maybe a regional block or catheter and the pain service afterwards, plus lignocaine and magnesium that some pain physicians run as well. And post-op care, potentially HDU because complex pain reasons, and if there's bad lung disease as well, on top of a complex patient. Any one, let's say you have a 70-year-old full bowel operation, that's, moderate complexity, add in lung disease, add in post-op pain issues, and suddenly you have enough individual reasons combined to make it complicated enough for a HDU setting. Say you have a 70-year-old bowel obstruction, septic, blood pressure with ischemic heart disease, blood pressure of 70 and having ischemic heart disease and severe COPD. Think about your pain plan for that. Maybe during the break, think about that scenario. Then also think about a 3-year-old for removal of foreign body from a nail bed who's well and fasted. And then think of the tonsillectomy patient. And I'll just quickly go through those answers. I want to keep this as interactive as possible. I want you guys to have a go at these decisions, because it's your ability to make decisions, no matter how bad they are at the start, they'll just get better and better. And I want you to get really good at making those decisions earlier on in your training, because that will show, expertise and show competence really. Hey guys, while everyone's kind of rolling back in, if anyone has any questions, feel free to ask.
Sorry, one that came up in our group discussion earlier.
Yes.
I think it was the asthma patient.
Mm-hmm.
A patient was wheezy
yes.
for some sort of operation.
Yes.
Is there any role for steroids in that situation?
Oh, look, my personal experience of having asthma, steroids do work pretty quickly in my own experience. It's thought that, it takes hours to work. If you were to give hydrocortisone once they're asleep, absolutely. The fact that we give dexamethasone intraoperatively anyway, I'll definitely do that. Whether I do it beforehand, I don't think there's too much harm as long as you don't give it too quickly in an awake patient, because of the perianal burning that just happens to occur just really randomly to these patients. Yeah, that's a really good question. Every single time I've given nebulized Ventolin and ipratropium, it's always sorted it out pretty quickly, so I've never needed to give the hydrocortisone as well. Good, let's get started. So these cases here, I'll again, just in the interest of time, I'll run through the plan. Hopefully you guys have come up with a plan as well, and just getting used to talking through those. So for this, a GA, triad of analgesia, I'll need all of them: sedation, analgesia, and paralysis. Airway is an endotracheal tube. I'd want standard monitoring and an art line, and maybe even a CVC. So this patient, septic, they really will require decent fluid replacement and noradrenaline because of that systolic blood pressure of 70. Everything is leading to this patient needing to be managed in a surviving sepsis type of way. Early NORAD, early fluid resuscitation, maybe intensive care, broad spectrum antibiotics, and then fentanyl, ketamine post-operatively for pain, and then post-op care, maybe a HDU or ICU. 3-year-old, removal of foreign body from a fingernail bed, well and fasted. So this is a very typical case for most of us, doing a bit of pediatrics. And again, just to understand that most times if you don't have a drip in, you'll probably do an inhalational induction. You need sedation and analgesia. Airway is often a small pediatric-sized LMA. Monitoring is pretty standard. And then it's often just fentanyl and a local anesthesia ring block for these cases. And post-op care is on the peds ward. 18-year-old for tonsillectomy with Crohn's disease, stable and well currently. And again, this is just a bit of an insight into the fact that you'll need a GA for this patient. Often surgeons can do this case without paralysis and without an endotracheal tube. So sedation, analgesia, and LMA is pretty common these days, but often you need an endotracheal tube and a throat pack as well. Monitoring is pretty standard. Pain, again, multimodal, and I'd particularly ask if celecoxib is okay with the surgeon because they might be worried about any post-op bleed risks. And then post-op care is often the ward, if not a day procedure.